Welcome back to Medical Mondays. I'm here with Dr. James Gray from Tennessee Oncology. Glad you're with us as well. If you have a question about radiation therapy as part of cancer treatment, go ahead and give us a call. We've been able to answer a lot of those calls tonight, and the lines are open right now. So 615-737-PLUS is the number to call. Before the break, we were talking about seed implant therapy, and you told me, and not in a bragging sort of way, but 20 years ago, you were the first one to try this here in Tennessee, and it's evolved a lot in those 20 years. What is it, though? Explain it in layman's terms.
Okay. All right. Doing a radioactive seed implant for prostate cancer entails placement of small radioactive sources actually inside the prostate.
And these are like the size of a
it's
rice?
like a 1/4 inch long piece of pencil lead.
Wow.
That's what it looks like. Okay. And it slides down the inside of an 18 gauge needle, which is the size needle we oftentimes will draw blood with. Okay. So not a very large needle. So the principle is to put these seeds inside and even right around the edge of the prostate, and they are left there. It's a permanent seed implant. That's the most common technique. There's a couple of different ways of doing that. And placing the seeds in a way that they will stay there for the gentleman's life. But they only give off radiation for a period of time for about a few months. And during that time, though, they can give enough radiation to the prostate to kill all of the cancer cells. And this has been a hugely successful way of treating prostate cancer over the last 2 decades. Back in 1996, I worked with several other doctors here locally, and the newer technique, which allows less invasive approach, where we place the needles in through the patch of skin right behind a man's scrotum, and that allows us to introduce the needle, not pass through the rectum or other tissues, and it goes into the prostate. And we do this with ultrasound guidance and some X-ray guidance. And the seeds are placed in a very specific pattern that allows us to deliver the right amount of radiation for that particular man's circumstance and the size and shape of his prostate gland. And we can send the gentleman home from the operating room a couple of hours later.
You told me you did this operation this morning, and the gentleman's at home tonight.
Right. He probably was home for lunch, honestly. It is an outpatient procedure, but it does have side effects, and we have to monitor that and make sure that the patient is the appropriate person for that type of treatment. But when it's been looked at and reviewed over the years at multiple institutions, we find that for early stage prostate cancer, it seems to offer the absolute same cure rate as we see with removing the prostate.
Well, that's very encouraging. We're going to talk about more of that in a moment, because we have a lot of questions when it comes to this. But I do have Helen on the line. Helen, go ahead with your question. I want to make sure you're not hanging on the line too long.
Are you talking to me?
Yes, ma'am. Go ahead with your question.
All right. I just wanted to comment on the therapy. It's a targeted therapy that's called brachytherapy.
That's what we're talking about right now, yes.
All right.
What was your comment or question? Helen, make sure you're listening to your telephone and not your TV.
All right. Is it still available, and is it recommended?
Okay, great question, because that's exactly what we're talking about right now.
Right. Well, brachytherapy is done commonly. As I said, I had a gentleman just this morning. I'm scheduled to be in the OR tomorrow morning to do another gentleman. It's a fairly commonly applied procedure for prostate cancer. It is also very commonly used in women's cancer, such as cervix cancer or endometrial cancer. It is also used a lot for breast cancer. Is one of the ways we deliver radiation for breast cancer, called breast brachytherapy, or accelerated partial breast irradiation, which is a mouthful. I have patients where I work with ophthalmologists, retina surgeons, to place radioactive sources behind the eye, in essence, to give radiation to a tumor that's within the eye, most commonly a melanoma that arises within the eye. So brachytherapy has been used all through the years of radiation therapy for a very effective cure rate and minimizing side effects as one of the ways we treat all these different cancers.
So who is this right for? What kind of patient will benefit the most?
Well, the most common one that I'm involved with because of my personal practice is prostate cancer. And so the use of brachytherapy for prostate cancer generally is applied to the earlier stages of prostate cancer. More advanced stages of prostate cancer, brachytherapy may not be the right approach. It won't comprehensively treat the disease, although it can be combined with other approaches such as external radiation therapy. But prostate brachytherapy is a relatively minimally invasive and convenient and relatively inexpensive way of treating prostate cancer, but it's only one of many different options my consultations with a man who has prostate cancer will be very involved in looking at all of the options for how he can be treated. We, for example, don't need to treat some men with prostate cancer. So that's one of the questions we have to look at. Some gentlemen who are older with a very minimal early stage prostate cancer, we can pursue something called active surveillance, in which we watch his PSA and repeat his biopsy. Maybe he doesn't need treatment immediately. Ranging all the way to more advanced forms of prostate cancer, where if we don't treat it urgently, it will spread and create a lot of problems for that gentleman and threaten his life. And then the list of options for him could include surgery, it could include this brachytherapy or radioactive seed implant, it can involve external radiation therapy. That can come in the form of IMRT, it can come in the form of proton beam therapy. There's even techniques called stereotactic body radiation therapy, also for more earlier stage prostate cancer. We use a device called CyberKnife at Centennial Medical Center to do this, and it shortens the course of radiation therapy down to, say, 5 treatments.
Wow.
It's almost a way of doing a brachytherapy-like radiation delivery, but from an external machine that's a robotic delivery system.
So you're talking about these modules that get injected into the body, full of radiation.
Right.
What happens to them?
Well, the radiation decays. It goes through a process called radioactive decay. So I tell patients it's like these are tiny little light bulbs that give off a light that's invisible, and it kills cancer cells. But the light bulb's on a battery pack. And after a while, the battery just runs down. And we leave the darkened light bulbs in the body because we don't need to remove them. The shell is made of titanium, which is a very tough and inert metal that doesn't bother anybody, doesn't set off radar detectors.
So you're not going to go through the airport and they're, what's in here?
Exactly. People are concerned about that all the time. They ask that question. It's a very good question to ask. And so they do emit a little radiation actually at first that we have to monitor and make sure it's okay, but very, very low risk to anything except children that are staying right next to that patient a long time, so we give them some precautions on that. But they're not walking hazards, so we wouldn't be allowed to discharge them from the hospital. So that's one of the really effective ways of treating prostate cancer. But every time we look at prostate cancer, we have to look at the whole range of possible options, which include not trying to treat it immediately to using surgery, which remains an excellent tool. And I have a lot of excellent surgical colleagues here in Nashville that know how to use robotic techniques to do surgery. Lots of forms of radiation therapy, pretty much all of which I have experience with. And I have a lot of partners throughout Tennessee Oncology. We have 11 different sites that do radiation therapy between Nashville and Chattanooga, and have a lot of colleagues with a lot of expertise at doing that. I'm just one of them. So a lot of ways of treating prostate cancer.
We have 2 more calls on the line. We have Ray and Kathy hanging with us. Ray, let's talk to you first. Ray, go ahead with your question.
Hi, guys. My question is, 8 of my male family members have died of prostate cancer.
Go ahead and listen to your telephone. You can turn down that TV in the background, Ray.
Okay, just turn it down. Okay, my question is, 5 of my family members have died of prostate cancer. I'm 60 years old, and I've had a lot of prostate problems. Is prostate cancer hereditary?
Yes, it is, to a certain degree. That because you've had family members die of prostate cancer does not mean you are going to develop prostate cancer, nor does it mean you're going to die of prostate cancer. But it does mean you need to be on a little bit more of a heightened alert. With that many members of your family having prostate cancer, you should probably be screened. I think most experts would agree. And you should have PSA testing, you should have a digital rectal exam. These can be done by your family physician, or you could see a urologist. A urologist is the expert at doing things specific to the prostate and determining whether or not you have prostate cancer.
How often should he do this?
Well, certainly he should have baseline measurements. If he's had that much hereditary background, then find out what the PSA is now, determine whether or not a biopsy is indicated at this point. And on an ongoing basis, either yearly, or it could be argued maybe to do it every other year, but with that much history, I think a yearly PSA might be prudent.
All right, Ray, thank you for calling in and hope that helps. Let's talk to Kathy now. Kathy, thank you for calling in. What's your question?
Yes, thank you. I'm calling about my 86-year-old father who was diagnosed 2.5 years ago with stage 3 melanoma of his ear. And a portion of his ear was removed locally. He's up in Ohio. And they found in-transit metastasis that was not visible but showed on the pathology report. So it was recommended locally in his town that he have radiation therapy, and he researched that, option, and then he also went to the Cleveland Clinic where they said they had further surgery that they could offer him. So he did end up going with that, and a good portion of his ear has been removed, and they also did not a full lymph node dissection, but a selective lymph node dissection on that side. All of those were negative. The further portion of the ear at the Cleveland Clinic was negative, but 3 days after the surgery, when they were reviewing the pathology from the first surgery near his home, they saw that he had perineural invasion that was not known before the surgery and not seen in his town on the path. So then they went back to recommending radiation therapy and even immunotherapy, but he did decline those therapies since he felt like he'd already chosen surgery. But my question is, what is the best way and the best type of doctor for follow-up for, potential recurrence of this cancer?
Well, a lot of dermatologists have a lot of expertise in managing and following melanoma, but perhaps I'm a bit more self-conscious of my own group. A medical oncologist can bring a lot of expertise to this to look at when adjuvant therapies are necessary. And adjuvant therapy is an additional therapy on top of what would be the primary therapy, which in this case was surgery and was appropriate. And having a lymph node dissection is frequently done, not always necessarily in a man in his mid-80s, but still is quite effective even in that age population to make sure that the cancer had not spread any further. The use of radiation in that setting has been shown to decrease the likelihood of the melanoma coming back. It's not been clearly shown that prolongs survival in patients in that setting, but the use of immunotherapy now is becoming much more widely used. Different targeted immunotherapy agents have shown their effectiveness in melanoma, and I have colleagues within Tennessee Oncology that are national experts at looking at this and conducting new research that we have going on at Sarah Cannon Research Institute, looking at how to combine newer immunotherapy agents, how to use, when to use radiation or surgery, and how to combine these different approaches. So a medical oncologist consultation, I think, would be key here.
Mm-hmm. Okay, and he did already have a hem-onc doctor because he has chronic anemia.
Mm-hmm.
And
as long as that physician does, some hem-onc physicians in different parts of the country focus more on only the liquid tumors, if you will, because they're hematologists. Make sure he has experience with what we call solid tumors. In today's world, most hematology oncology physicians will have that joint experience with solid tumors.
But worth asking that question.
That person, he has all the spokes to the wheel, but I wanted to make sure he had the hub.
You got that right. Kathy, thank you for calling in, and thank you for watching. Appreciate that. Good to have those guardians in your life, a daughter watching out for a father. Absolutely. That's for sure. And you were talking earlier about the age has to be considered when you're talking about quality of life and what treatments to seek out, because cancer treatments can be very hard on the body.
Right. Right, absolutely. We have a lot of patients in whom our ability to deliver chemotherapy, to take them to the operating room, to deliver forms of radiation are limited by the patient's overall health and what we doctors call performance status, which means what is their overall health status? What's their body's ability to tolerate? Any form of therapy has a certain level of toxicity, side effects, risk of complications. All of our therapies, unfortunately, have the unfortunate side effect of targeting healthy cells. Most of our bodies can take that and recover, while we design it to make the cancer cells overwhelmed by this toxicity. They don't recover. And that's the key to all forms of cancer therapy, whether it's surgery, drug therapy, or radiation therapy. In an older patient, their reserve just may not be as high. They may not be able to tolerate the anesthesia from major operation. They may not be able to recover from a certain type of abdominal or thoracic surgical procedure. They may not be able to tolerate radiation. They may not be able to tolerate chemotherapy. Age is a huge factor.
Without a doubt.
Right.
All right, we're going to take another quick break. When we come back, we will wrap things up here on this Medical Monday. Stay with us.